We are delighted to start the session on AI in human health with a plenary address by Professor Regina Barzilay from CSL MIT. She is well known for her work in natural language processing and on machine learning in oncology. A MacArthur Fellow, she is the first recipient of the AAAI Squirrel AI for Artificial Intelligence for the benefit of humanity. She'll speak to us on what AI can or cannot do for human health. One of the interest areas is in computational linguistics, where she created algorithms that learn annotations from common languages, that is English, to analyze less understood languages. Over to you, Professor Barzilay.
Hi, thank you for the introduction and good morning. Again, the title of my talk, What AI Can and Cannot Do for Healthcare. And the reason I think this question is very pertinent today is because AI technology becomes, stronger and stronger by the day, but at the same time, we don't see a lot of AI implemented in the healthcare system, at least in the United States or in Europe. So the question is, what this technology can actually do today, which is safe for the patients and effective for the healthcare system. So if you're looking at the whole landscape of AI methodologies that is applicable to the healthcare, you can, roughly speaking, take all this very heterogeneous technology and divide it, in my opinion, into these three groups. The first group is automating tasks that humans can do. And currently, this is maybe the biggest bucket of technologies available. The second one, automating tasks humans cannot do. Those are the things that machine can do better than domain experts due to their ability to remember humongous amounts of data and identify very subtle patterns. And the third technology, which is really just emerging, and there are very few examples in this yellow bucket, it's technology, AI technologies that enables us, or clinicians, to learn some new insights from whatever AI system learned. In other words, the question here is, can this technology tell us something new about human health, about underlying biology that we didn't know before? And as I showed below on the slides with a very big arrow, there is really a progression from blue to yellow. And even though today we're primarily in a blue-green area, the hope is that as field matures, we're going to move more into the yellow field. Okay, so let me show you a few examples of what AI technology can do to automate tasks which humans are already doing today. So maybe the most common example, so that we can see a lot of AI, relates to extracting information from patients' records. So you know that today, in order to identify patients for clinical trials or to select, particular retrospective group of patients to study about them, you need to have a human who goes and extracts information because it is all written in natural language. So a few years back, we have developed a system that can take the information about, in this case, it was patients about with breast cancer, and extract from their pathology reports all the features of the disease. So as I'm sure many of you know, cancer has different biological biomarkers. It also has different measurements, including the size, including whether it affected the lymph nodes and so on. So the system can go and extract up to 30 different measurements about patient cancer from the pathology report. And you can ask yourself, what exactly does it do to the healthcare system? And here you can see one example how it can really change the way we are studying the disease. So for instance, there is a type of disease which is called atypia. For instance, it can be a breast atypia, which means that the patient has cells which are not normal, but not cancer. They're just the typical cells. Like millions of women are affected with this condition. It's very well studied, but you can see that in the New England Journal of Medicine, which is considered maybe the top journal in medicine, the article about this phenomena shows only 674 patients with this condition. And you can say, why? There are like so many women with it. Why only like less than 1,000? And when you start reading this article, you understand why. Because the clinician had to go by hand through 10,000 different female patients to identify the ones which have atypia and don't have cancer. Because you need to do this kind of manual extraction and validation. If you use the systems that I just presented to you in one hospital, you can find, with a click of the button, with just one query to the database, you can extract 6,000 cases. So what it shows to you that you can really study a disease at scale if you have machine which extracted you the right information. The second example that I wanted to show you relates to cancer detection. And this is maybe one of the most common areas where machine learning is used today. In radiology, you take an image and, for instance, you aim to predict cancer. And we have the system that does it deployed in Massachusetts General Hospital. Now, at this moment, I would like to take a few slides and talk about one myth that at least prevalent in healthcare system in the United States. And this is a quotation from a noted data science person who is a clinician in Massachusetts General Hospital, who is kind of saying to us that you don't have to be computer scientists to participate in the creation of AI. That, if you're even a clinician, you can easily do it. And I'm sure that those of you who are AI people in the audience, you are more familiar with the statements from Andrew Yang that is saying that, AI is like electricity, we all can do it. Like I am not, I don't, even though I'm from electrical engineering and computer science department, I don't know much about, electrical engineering, but I still use a lot of electrical devices in my house. So the idea is the same, everybody can do AI. So this is really, really wrong. And I want to show you it's numerically. So if you're looking, so one option, let's say you want to do a new cancer detection task. You can just go and use standard architecture of, let's say, ResNet or whatever is available at that moment and run it, and you're going to have a detection system. The next step is to do what, people who took a machine learning or computer vision class, who are computer scientists, but not really specializing in it. Those are the yellow things that they will do. They will maybe do some image rotation. They would initialize the model correctly and do pre-training. They will think how to do optimization. This would be a yellow system. So here again, we're taking one step from just downloading from something online. And then the green part is what you will do if you really are specializing in computer vision and you are trying to develop a system which can really do something very novel and something which is specific to, let's say, breast cancer detection. So you can see that, for instance, you can change the objective by modeling how risk progresses over the time. You can try to learn invariant representations that enables you to generalize across the devices. You may do some image registration, because whenever you do the, let's say, breast mammogram, which is an X-ray, you take various views and you need to align them. So there are lots of different things you can do in a smart way. And what it shows to you here, it shows you the difference in performance across the three different ways to approach the problem. So the measurements that I'm showing you is called AUC, area under the curve, and it varies from 0.5, where you just do random guesses, to 1. And you can see that the model that just took this software out of the internet and ran it on the patient data gives you 0.57, which is very close to random. If you do kind of right computer science / machine learning things, you get a big boost, you get to 79, but you get really very close to top performance by utilizing this kind of customized model building capacity. And in healthcare, we care very much to get as close as possible, to a perfect answer. Therefore, it really matters to create smart models that can achieve higher accuracy. Okay, so now that we looked at some tasks that were machine automating what humans can do, now let's start looking at the tasks when today humans are not even attempting to do them. So an example of such a task, predicting the future disease. Today, whenever you're diagnosed, you go, somebody, let's say, sees a disease, let's say it's cancer, or it can be something else. But what we ideally want to do is to say what's going to happen in the future. That somebody looks at the image and tells us what's going to happen with this patient in 3 years. Because if you know that this patient is very high risk, and we know it with a sufficient accuracy, there are lots of things we can do to help this patient. Okay, but we can say is that we don't only have to use images, we can also use, for instance, pathology slides, we can use sequencing information about the patient, we can use, medical records, a lot of stuff. And what we want to do, we want to be able to predict recurrence, to predict sensitivity to treatment, to identify population at risk. So there is a whole bunch of tasks for different diseases. It can be cancer, it can be neurological diseases. And even today, during COVID, the question is which of the patients is going to have it really bad? So those are the examples where, human experts don't really know the answers, but machine have a chance. Because again, machine can find very subtle patterns and it can look at huge amounts of training data. Now, the question here is again that, remember, human doesn't have a biomarker. Human doesn't really know why the patient is at risk. But what you can do, you can give to the machine, let's say patient image, you can give the outcome and make the machine learn to predict that outcome, kind of taking a human experts out of the loop. But then it brings a lot of questions for us to answer, which is how can we define outcomes? How can we ensure that this model will generalize and how we can interpret these models? And you can say, if I want to predict cancer, it's easy. I just want to say identify cancer, but maybe this is not enough. Maybe what you want to say, you want to identify the exact type of cancer, because then you would know how aggressive the disease is likely to go. Or you want to know what subcategory of cancer in terms of treatment. For instance, there is something which is called hormonal positive cancer, which has, for breast at least, which is 80% of the cancers. For this cancer, actually, there is a drug that you can take which greatly decreases your chances of taking it. So if the machine can tell you that this is the type of cancer you're going to get, you actually have the therapeutic that can help you. But if you have another type of cancer, it will not do anything. So there are a lot of questions you can ask. You can make them very detailed, these questions. But of course, we need to balance the clinical significance and the data size that you have to answer these questions. And of course, whenever you're annotating the outcomes, you need to, again, balance annotation cost and annotation quality. And let me show you some examples where things went really wrong when people incorrectly did these annotations. So there is a very big case that is undergoing in the United States. It's started maybe, this year or last year, I think, yeah, it's last year. The group of researchers identify that an algorithm that is used in multiple clinics, that was applied to millions of people, is actually racially biased. This algorithm was supposed to predict, when the patient is hospitalized, how likely that the patient will have a severe disease. So in case if the patient is likely to have a severe disease, you may treat them, have a different treatment pathway, and, look more carefully what's going on. But what it turns out, that this algorithm, if you take the white person and black person, African American person, it's more likely, with exactly the same condition, only different based on race, it will not identify African American person as sick, while it may identify the white person with the same symptoms as sick. And the reason here had to do with the quality of annotation. So the way the algorithm was trained when it was developed, they decided that how do you know who is sick? So one way to do so, they look at treatment codes. They're called ICD-9 in the United States. So since due to various socioeconomic inequalities, patients that had, African-American patients, many of them didn't get the treatment they needed, even though they were very sick. But the algorithm didn't know why they didn't get this treatment. It just knew that they didn't get this expensive treatment. So they were defined less sick than they were in reality. So this is an example that the way how you give the system, the meaning of sick, which was related to these payment codes, introduce existing bias in healthcare into AI system. So another example, which is not related to race, but it's related to clinical definition. So this is an example of papers that was published in New England Journal of Medicine that talks about overdiagnosis. So many times when pathologists look at the image, at the slide of the biopsy, they have their own different understanding. And some of them are more likely to say that they see cancer, for instance, than others. So if there is somebody who systematically, sees cancer where his or her colleagues don't see cancer, if you are to train an AI system, it will capture this internal bias, and AI system will learn to overdiagnose. So the second question is, how can we ensure that these models can generalize? And this is actually an important question, and it has to do a lot with the disparities in clinical care. So can AI actually worsen the existing health disparities in the system? And in the United States, many of these disparities, relate, unfortunately, to patient demographics. So one important thing to understand whenever we're talking about AI system is that the assumption is that your training population on which you taught the system to identify the pattern and your testing population are very similar to each other. And let's say you train it on this, you randomly split your population, you train on some portion of your data, you test it on another portion of the data, and you got some really high performance. But now, whenever you are testing it, you actually have slightly different population. And this is always true, because even if you go to the same clinic over time, there are different people coming in and so on and so forth. Or even in a more extreme case, you may have trained your system on one clinic, but now you're taking AI and applying it to other clinic, where there will be different population, maybe different ages, maybe different stages of disease, maybe different races, and so on. So, and in this case, whatever guarantees you had on the performance prior, they don't really work on this new population. And again, as I said, it doesn't have only to be demographics. It also can be clinical setting, whether the patient is treated it like top research facility versus maybe they're treated in the rural hospital, what kind of device is used, and so on and so forth. And the problem is that if you're thinking about the AI system, about the bias, you should acknowledge that even in traditional systems, bias was already there. And what I'm showing you here is a system which is currently clinically used in the United States. It's not an AI system, but this is a statistical system that aims to predict future cancer. So you see, it doesn't work well for anybody. Remember, the random means 0.5, but it clearly shows to you that it performs much worse on African American and Asian women where it's close to random. So the good piece of news that if you are to train an AI system on a diverse, racially diverse population, you can actually see that it sustains good performance across different patients groups. So this is, I guess, a very good piece of news. But you really need to be aware and to make sure that your training has the desired diversity that you need. And you can see that, unfortunately, even today, when we are looking at the top publications in AI, people are still not thinking of the importance of showing how the model performs across different populations. And you can see in this case, there was an article in Nature about breast cancer AI system. It was tested on US and UK cohorts, but we never seen how well does it perform on different races. Is it safe to use system in the real diverse population? And the other thing that I wanted to know that many times the challenge is that the system may have biases that we don't even know about. Because, sometimes you say, fine, I can check it on different races, but there are many other biases that the system may learn. And I want to give you an example of my personal experience in my group. When we started working on the system for predicting cancer from images, at any stages, we all of a sudden get the accuracy of 99% on the test, which we knew cannot be the case. And it took us a long while to understand what was going on. So it turns out that the data, which was not our data, we haven't collected it, we just got it from the hospital, was constructed in a very strange way. All the positive examples, let's say, I don't remember the years, but let's say they came from 2010 to 2012, and all the negative examples, let's say, were from 2013 to 2015. Now you say why it is a problem, because actually in reality they changed the machine that takes mammograms in between. So the images with positive examples were taken by one class of machine. The images with negative examples were taken by another type of machines. And in the middle, this change now let the machine not to learn who has cancer or who doesn't have cancer, but just to learn to predict what type of machine was used. Since in the testing, it fully correlated with the cancer outcome. So the task of detecting which machine is used is a trivial task. It's a deterministic task because there is like a seal of the machine. So the fact that we can do it perfectly didn't say anything about being able to apply these methods, to real images. So this is an example where you're not aware that your data has bias. You can be very happy because you're getting high accuracy, but the model actually doesn't learn anything. And you can say maybe this is really an exotic example, but there are lots and lots of cases which are similar. For instance, the paper which I cite below on the slide had a very similar case where the source of bias was related to the origin of the images for pneumonia. So apparently in their training and testing that use images from several hospitals, and some hospitals had lots of patients with pneumonia, other hospitals didn't. So if you pretty much look at the hospital with high accuracy, you can say what is the likelihood that the image will have pneumonia even without looking at the image. So again, the point here is that we really need to be aware of what kind of nuisance variation the model learns when it is applied. And the final point is how we can interpret these models. And it is not always easy to interpret what the model is doing, but whenever we can do it, it can actually prevent us from being a victim of this kind of nuisance variations in our data. So in some cases, let's say if you're training the system which tries to identify cancer, you can, for instance, ask the model to say which part of the image you're looking at when you are predicting cancer. Or if you're extracting something from natural language, you can say which part of the documents that you use when you predict something from NLP. It becomes a bit more tricky as to what explanation a human can receive when we do tasks, as I said earlier, which humans cannot do it. Humans cannot look at the CT scan of the patient and say whether this patient is going to have pancreatic cancer in 10 years from now. We cannot do it. So it's not clear to us what it would even mean if the system kind of visualizes or provides a rationale that it took, because it's so hard for human would be so hard for human to understand because they cannot do the task. But for many tasks where machine, we can sort of understand how the outcome correlates with your input data. Using interpretability is really important, and there is a lot of work in AI on trying to build this interpretable model. And the final thing that I want to show you is how we can derive new insights. As I said earlier, this is really very beginning stages. There is very little done here, but I will show you some few examples from my work. So I remember that when we started developing the model, this is one of the early models that predict cancer risk. We saw something which didn't make sense to us. Which is if you're looking at the model that just looks at the image, it gets some number. If you add to it all the information about the patient, you would add information about their age and about like some prior diseases and other things, the difference in accuracy is very small, whether you're looking just on the image or you add this extra information. And this was like, why does it happen? Why this information that we know correlates with an outcome doesn't help? And what we found out is it turns out that looking at the image alone, you can actually predict a lot about a woman, about her risk factors. So you can just look at the image and predict the weight or the age of the woman or whether she had children and other things. So it turns out that all these different factors, they're already imprinted in tissue. So if you are adding them directly, actually, you're not adding a lot of information. You are pretty much already have it in the image. So it's not, there is very little value. So another interesting question that people really have limited understanding of is, when the cancer starts to develop, is it like, okay, the person got cancer diagnosed, let's say in 2010, for how long did the patient had cancer in their body? So one way to look into it is to look something which is called attention, which is again this mechanism, you can see it here in yellow, that it shows you parts of the image that the model looks at when they predict the future risk of cancer. And here you can see how, the light yellow shows where the model looks at when it predicts that the patient is in high risk of cancer. And you can see how these yellow things change for the same patient in 2009, 10, 11, 12. And the green button shows you where they eventually found the cancer. And if you look back at these images, you can see that the patient had this area highlighted for quite some time. And you can do more precise computation about, this heat map. And you would see that as we get closer to the diagnostic, it focuses, of course, on cancer, but the process itself starts years earlier. So this is again something we can study on humans, a question that wasn't studied really before because nobody can look inside your body, 5 years early, but you can extract this information by analyzing, this medical test. In summary, today I showed you, 3 examples of how AI technology is used. We can already see a lot of examples when AI can automate us and be more effective and consistent on the tasks that humans are doing. We are seeing increasing number of cases where AI is used to do tasks that humans cannot do. And we hope that as we progress in developing better AI technology, we would be able to derive new insight and to understand something novel about human health. And I want to conclude my talk by saying it's really not about competing with humans or become better than humans. It's about how to find a symbiosis which will bring human power and machine power together to have better health outcomes for patients. Thank you.
Thank you, Regina, for the wonderful talk. One quick question, actually, and it's kind of interesting since you talked about it, is the ability of AI to actually scale bias. And that's why it is not so simple to use. And I think that's a very valid point. I mean, we all have biases. I mean, because of the way we are brought up, we have biases. But it's the ability of AI to scale the bias that's actually makes it a lot more trickier to actually handle. I think that's a beautiful point that you pointed out. Other thing is kind of interesting to ask you is like when you talked about adding more and more information and so have you also looked at adding different kind of images, right? I think we have one of the panelists, she runs a startup which is leveraging thermal images to detect breast cancer really early. So have you also looked at, is there, will we get better outcomes if we actually start combining different kind of senses into our analysis?
Thank you. Thank you for the question. So let me start with the second question about the different type of images. So even today, I just gave my examples primarily in the breast cancer area where mammogram today is the most, common thing used, at least in the US clinics. For other diseases, we are using, for instance, CT scans if we're looking at the pancreatic cancer early diagnosis, or if we're looking at lung disease, or the sensitivity to treatment in the case of lung patients, we're looking at the CT scans. For instance, moving to this modality brings additional challenges because the CT images are humongous. You need to do kind of smarter things from the AI viewpoint. You cannot load it in the GPU in the same way. So you really need to do pre-training and other things in a different way. So in this area, kind of going even to more sophisticated images, we are doing it. Now, we also had an experience with thermal images, but not in oncology area, but in the area of COVID diagnostics. We are working with a hospital in Mexico, where the goal is to be able to predict, the pneumonia and the likelihood that the patient has COVID just by taking the thermal image of their lungs, of their body from back. We do have, results on all these different fronts. I think that, to be effective, you always need to select modality which is available for you, which would be considered in your country something you can get. So in some developing countries where you may not be able to do very elaborate, diagnostics, like thermal camera can be really useful because you can do it to many people. You don't need to have qualified provider, and you can just immediately kind of assess who is likely to have a disease and maybe just send those patients to more sophisticated training. In other cases, because lung cancer is diagnosed with CTs scans, so you would want to do it on CT. But again, for each one of these modalities, you need to develop algorithms that work well on this modality. And again, it's very unlikely that people do, both X-ray and CT and thermal image. You typically use one modality for patients, but you can clearly see that if you can, for instance, predicting disease progression, if you can look both at the image of the, of the organ, and maybe you can use an image of the pathology from the biopsy, and maybe you can use the sequencing information about the genes of the patients, you can do overall better prediction, because all of these three different sources would have complementary information. And regarding your first question with respect to bias and AI, I think that AI actually has an amazing opportunity to remove many biases that are already in the systems. Because many of these models for risk and other things were developed, on white men. This was the default, not for breast cancer, but for many diseases. White men were on what the clinical guidance was developed and then utilized around the world. So right now, we don't have to do that. We can just take our local population with all the different features of it and create models for that population. We don't need to reuse the model that was developed in Boston on, in population in India or in Israel. We can develop with the same code, optimize it for the local population, which more likely will be more accurate for that population.
Yep. Well, thanks a lot. Thanks a lot for your time and, wonderful talk. Thank you.